This lecture will cover a brief look at 12 lead EKG. Next time we come together, come with your questions and we can go over anything that is not clear as mud on that day. I want to start just by showing you what a 12 lead tracing looks like on an EKG paper that you might see. Giving you this quick orientation now, you don't need to understand a lot until we get further into this, but it might just make it easier to understand down the road. So what you can see here is that we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. All of these are representing the exact same beat at the exact same moment, the same electrical activity, just at a different view of the heart. And then you'll see down here at the bottom that there's another tracing, and this EKG tracing is choosing one of those 12. Sometimes it can go up to 3 of those 12 that are there to watch more continuously than the snapshots you're seeing on this piece of paper. All right, so all this time we've been talking about simple EKG rhythm strips like the telemetry encounters that you've had when you are in acute care. I've alluded to 12 leads a couple of times when we discussed ST elevation and depression, but you don't see that on the strips that we discussed because that's only up to 5 leads or 5 views. And usually you only get to see one of those tracking at a time. So we're going to talk 12 lead for a bit, but just the basics. It does go to physics, some of this, so you can have to dust off some cobwebs. To start off, we have 10 electrodes that are attached to the client, and if you look at this bottom picture, you'll see. So we have 4 limb electrodes, arm, leg, and leg, and then we have 6 chest electrodes, V1 through V6. Those combine to give us our leads, and leads means views. So we have a view of V1 through 6, so that's 6 views. Those are the chest leads. And then from those limb leads, we have 3 views that are very self-explanatory. Right arm, left arm, that's VR and VL, and left foot, that's VF. And then limb lead 1, 2, and 3, where are those coming from? Well, right is a ground, okay, so this is a ground electrode. So 1, 2, and 3 are combined. They combine different views together to create vertical planes between different sections of the heart. So just keep that in mind as we go along, okay? But all of that combines together, and what it does is it gives us these different viewpoints. So each EKG tracing looks a little bit different in the 12 different views, but it's all of the exact same electrical activity representing the exact same beat of the heart, which then allows us a diagnostic 3D view of the electrical activity, and it helps cardiologists then locate a problem. So this is the view of the heart and the 12 leads. That's what gives us that 3D picture. And so it allows us to say more than just what the rate or the rhythm is. And it's all about axes and vectors. So that's the next thing we're going to go over is axes and vectors. So as a review from physics, we're going to have to define a few things. So the axis is the direction of movement of depolarization. And I need you to keep in mind that electrical activity depolarizes from the AV node down through the ventricles, through that septum and through the myocardial wall, from the endocardium to the outside of the muscle wall. So it goes from the center out. Think of it that way, okay? So that's the vector. The axis is the direction of movement of that depolarization. So we draw all these little vectors or all these arrows that point in the general direction of depolarization from endocardium out and downwards because it's coming from the AV node down to the base of the heart. Keep in mind that this is from the inside to the outside. So this makes more sense in a minute, but I want you to think quickly about the anatomy. Which ventricle is larger? And if you have a thicker wall, if you had to draw an arrow, would that arrow be longer or have more magnitude? And that's how diagnosis will work. And I'm going to answer those questions for you, not to worry. There are many mean vectors that we can discuss, but the easiest one to understand, because it's easiest to see on the EKG strip, it's also easiest to understand in terms of what's happening in the heart, and it's the ventricular contraction. So the mean QRS is the one we're going to discuss. Remember that QRS on the EKG strip represents depolarization of the ventricles, which represents contraction of the ventricle. Once the AV node sends the signal to depolarize, again, it begins at the endocardial lining and then moves outward through the myocardial walls of the ventricles at the exact same time. The thicker the wall, the longer or larger the vector, so that arrow that you would draw from the inside to the outside wall. Adding all of those tiny vectors together is going to give you a mean QRS vector. In the case of a healthy heart, this means that the QRS vector would point down and left because there is a bigger magnitude of vectors on the left side of the heart, and the depolarization is traveling downward from the AV node to the base. So down and left is typical. That's this in pictures. All right, so if we draw all these little arrows, each of these represents a vector of depolarization from the endocardium to the outside wall and coming from the AV node down. So they're all going to point downward and outward from the endocardium. You can see that we have larger magnitude vectors on the left side of this heart than we do on the right ventricle. So when we sum these together, the mean QRS is going to point downwards at about a 45-degree angle down and left. So now that we've covered the vectors briefly, let's talk about the axis. Recall that we defined axis as the direction of movement of depolarization. So in the case of the QRS, mean QRS vector, it's down and left at about 45 degrees. And so that's also our normal heart axis. It's based on that mean QRS. So the heart axis is 45 degrees down and left. What this is noted is because if the heart is displaced, say it sits vertically or horizontally in the chest cavity, then the mean QRS vector would change. And if that changes, then it changes everything about how we read the 12-lead EKG from the very beginning. Because remember that the AV node is always going to be the tail of the mean QRS vector, and then we're summing all those tiny arrows to one mean vector. This is important when we get into interpreting, because if a heart is more vertically arranged in the chest cavity, then the QRS vector is going to point closer to 90 degrees or straight down, right? So here's a vertical heart here, and if we're summing this up, if we've shifted the whole heart around, I hope you can understand that this vector would also shift closer to 90 degrees. Versus a horizontal heart, then we've turned this whole thing up, and now our mean QRS vector is pointing towards 0 degrees. This does make a difference in interpreting QRSs and interpreting what's going on in our 12-lead EKG. One more thing to keep in mind always. Negative is towards the head, positive is towards the feet. 0 is towards the left, and 180 is towards the right. This will make, if you know this, it'll make understanding the next section a little bit easier. So again, head negative, feet positive, left 0, right 180. And remember that depolarization is a positive wave towards the electrode in reference, okay? Why does this all matter though? Well, if we know the axis is normally 45 degrees, then medically, if something happens and we know the heart is in normal alignment, then a change in what the mean QRS vector and changing what the QRS waveform is doing in each of those views will give us an understanding and indicate the type of pathology that's present. So if the left ventricle were hypertrophied, meaning that there was a thicker wall, then the magnitude of those vectors on the left, what would they do? And what would the cause of the direction what would cause the direction of that mean QRS to do? Would it move? And what if instead there was an infarction in the left upper ventricular wall? What would that change about vectors and the mean QRS? We're going to talk about it, but this should get you thinking a little bit, so think about it. To answer those questions posed on that last slide, here we go. If I have a hypertrophied left ventricle, the wall is thicker, and therefore the magnitude of the vectors on the left are larger, meaning that the mean QRS vector is going to shift up and left. So I have more magnitude going this way versus my right because I have a hypertrophied wall, and so then my mean QRS is going to shift up and left. If instead I have an infarcted area, then I lose the vectors completely in this area because there is no electrical activity, so there is no vector. So now I have less magnitude than I did previously. This is my normal, and so all of a sudden my mean QRS shifts to the right. This is important because this is going to change how it looks on an EKG strip. So let me stop that for a minute and see if I need to draw anything for you. I don't think so. So summing those up means that if we understand these mean vectors, then that's going to help us understand what happens to the QRS on each of the limb leads. So let's connect those dots for you a little bit here. Remember I said that depolarization is positive when it's traveling towards an electrode in reference, and if it's traveling away from the referenced electrode, it would be negative. So they're not all going to be positive all at the same time, meaning that if the QRS is going towards a specific electrode, then it's going to deflect on my EKG as a positive waveform. If it's going away from the referenced electrode, then it would then be a negative tracing or waveform on an EKG. So in the case of our QRS, remember that typically, I'm going to draw it in here for you, typically this would be the mean QRS, down and left 45 degrees. If we're referencing limb lead 1 here, then you can see that this is towards limb lead 1. And so that towards limb lead 1 then means that we would have a positive QRS when we look at lead 1. However, if instead we had a shift of our mean QRS over here to the right, for whatever pathology that's causing that. That could be an infarction in the left ventricular wall, hypertrophy in the right, etc. Whatever's making us have this shift of our QRS to the right, mean QRS, then now when we look at limb lead 1 as a reference, we see that that vector is going away from here. And if it's going away, it's negative, meaning that when we read the QRS on that EKG strip, now all of a sudden QRS is negative instead of what we've been used to, which was positive. So another example to explain this, using AVF. Remember, this is the foot lead on the left foot. So typically we would have a mean QRS that's pointing like this, right down in this direction, which would be a positive QRS wave, which is what we're used to, just like this one down here is a positive RS wave. If that's the case, then our vector would be pointing here. But if instead our mean QRS vector suddenly shifted upwards and left, now we're moving away from the AVF electrode. And so now AVF suddenly has a negative QRS signal on its EKG strip. And this would tell us that there is a problem that has shifted our QRS vector. Cardiologists don't just use one of the 12 leads to make a diagnosis, just like you can't do a single special test and not evaluate anything else to determine a diagnosis from physical therapy. So it takes looking at all the views of the heart to get a clear picture of what is going on. So if we take the AVF and lead 1 examples we just used, with the fact that normally those two on an EKG tracing would have a positive QRS on EKG, because if we're talking healthy heart, then if they're both positive, then we know that our normal axis range is within the 0 to 90 degree range. We said that normal is around 45 degrees. From those, we have 3 other axis ranges: left axis, right axis, and extreme right axis deviations. And that would mean that the QRS is pointing towards one of those instead. So I'm going to give you a better indicator of that in just a second. But what this does is indicates pathology. There's so many other components, we're going to talk about that as well. So using that example of the limb lead 1 and the limb lead AVF, so the foot lead. So if we have a positive QRS wave in limb lead 1 and an AVF, then we are in normal axis here. However, if instead there's a left axis deviation, we still are traveling towards 1. So in limb lead 1, our QRS would be positive, but we are now traveling away from AVF, and away would mean that we negatively deflect on EKG, so our QRS would go in a negative direction. If we then instead are over in right axis deviation, then we are moving away from limb lead 1, so we have a negative deflection on EKG limb lead 1, and on AVF, we're moving towards the foot still, right? Because we're still in a downwards direction. So we'd have a positive deflection on EKG. And then an extreme right axis deviation, we are moving away from limb lead 1. So we're going to have a negative QRS in 1. And we are moving away from AVF because we're moving up rather than down. And so we would have a negative flow on EKG as well. I would suggest that you stop here for a few minutes and digest the past few slides before you move on. So hit pause, stretch, look at your notes, and then come back for more. We're halfway there now. Let's switch gears slightly here and talk about the chest leads, V1 through V6. These are each monitoring a different part of the ventricle. The right ventricle is viewed through V1 and V2 here. V3 and V4 are monitoring the septal area. And then V5 and V6 are monitoring the left ventricle. And remember, these are going horizontally across the front of the chest. So these leads are all positive. They're all in the front of the chest. But think about what that means to the QRS vector. Remember, it's pointing positive 45 degrees down and left. So in V1 and V2, that would mean that the QRS should be negative on an EKG strip as it travels away from those leads. And then in V3 and V4, it should be kind of equal between a positive and a negative because we're kind of between those two. And then finally in V5 and V6, the left ventricle view, then because we're pointing down and left, there should be little to no negative and lots of positive QRS on an EKG strip. Remember, the vector is traveling towards the positive and away from negative. All right, so looking at V1, typically QRS is mostly negative. What if there was right ventricular hypertrophy though? Think first about the mean QRS vector. What would it do? As the right sums up more magnitude vectors because the right wall is thicker, it means the QRS would start to shift to the right and begin pointing further downward. And that would be more towards the V1, V2 leads on the right ventricle, which would cause a positive deflection of the RS complex rather than a mostly negative as it should be. In left hypertrophy, the mean QRS will shift further toward the head and left, which would cause a larger negative RS complex in V1, V2 as it moves further away from those electrodes, causing a bigger, larger negative deflection. Let's look at this in pictures so it makes more sense. It's all about the vectors and knowing what's normal. So let me orient you to this picture. So here are our chest leads, 1, 2, 3, 4, 5, and 6. Remember, 1 and 2 are looking at right ventricle, 3 and 4 are on the septal area, and 5 and 6 are looking at left ventricle. So if that's the case, here's our normal QRS. So you can see that if this is it, I'm moving away from 1, so I should have a negative QRS. I'm moving away from 2, so I should have a negative QRS. I'm moving through 3 and 4, so I have kind of an equal positive and negative QRS. And I'm moving towards 5 and 6, so I have a positive QRS. However, if instead I've shifted over here because I have left ventricular hypertrophy, meaning that I have summed up more magnitude here than over here, and so I shift that mean QRS to the left, now I have I'm moving further away from 1 and 2. So you can see in V1 and V2, I have a bigger, deeper S than I did before. In V3 and V4, I'm still moving away more than I'm moving through. And so now I have still some positive, but a lot of negative in my components. And then over here, I'm moving through these. So there's no negative, all very positive, very tall peaked QRSs in the positive direction. I'll let you sit with that for a minute while I move this to the next slide. All right, I'm not going to belabor you with more of the vector talk. However, we have atrial vectors too, and this is just one to just know or learn, okay? A diphasic P wave in V1, V5, and V6 is atrial hypertrophy. Diphasic P waves on the V's, think atrial hypertrophy. A large R wave in the positive direction in V1, think about that. Should V1 have a positive R? If not, if it is positive, then we're looking at right hypertrophy, and large R waves in the deep negative S wave in V1 would be left hypertrophy. So here's our deep left, right? And typically V1 is what? But if it's deeper than what? Okay, so think about that. These are all based on the mean QRS vectors and the location of the lead in relation to the direction of the vector from that lead. If you can look here and understand why in left ventricular hypertrophy, why we end up with a deep negative on V1 and V2 versus this is normal over here and here's deeper. And while we have a very positive V5 and V6, more peaked than this. And if you can also understand that instead of having a negative QRS in V1 and V2, instead they're positive here, that would equal right ventricular hypertrophy because of the shift of the vector. If this is making sense, you've got it. If not, go back and watch this part again and come with questions. I've spoken a few times about the ST segment and how it's used to determine ischemia versus infarction. So if T waves are inverted, this means there is ischemia. We can see this most readily in V1 to V6 as those are the ventricular specific, and that's often where we see ischemic or infarction is in the ventricles. These can often also be seen on a stress test. So if we see this this inverted T wave or this ST segment change its position, then that indicates a positive stress test and a further workup would be required. Digitalis can also cause T wave inversion, so we would want to check on medications and dosaging. ST segment elevation shows up when there is an acute MI. In the QRS complex, the Q wave in V1 to 6 is significant, meaning that the Q wave takes up more space than it should, and we'll go over this in a minute. So a significant Q wave meaning greater than 1 millimeter wide, or the amplitude of the Q component of the QRS complex is 1/3 of the amplitude of the entire thing, then that's a significant Q wave. That indicates significant necrosis of myocardial tissue. You've heard the term STEMI or non-STEMI, or STEMI and NSTEMI, meaning ST elevation myocardial infarction or non-ST elevation MI. The rule of thumb is that an ST elevation MI is worse than a non-STEMI in terms of degree of damage to the myocardium. Remember that an inverted T wave, which you can see here, means ischemia. ST depression also means ischemia. ST elevation off of the isoelectric line, because it should be isoelectric, right? We would have QRS isoelectric line and then a T. So this is inverted, it's in the opposite direction. This depresses below isoelectric, so it's ischemia. This ends up above isoelectric, so that represents an acute or very recent MI. And then the significant Q, so here we're talking it's greater than 1 millimeter wide, and here we're talking this 1/3, at least 1/3 the amplitude of the entire QRS complex is the Q, then that represents necrosis. All right, this is just definitions if you don't remember. So ischemia is reduced blood flow, infarction is cell death from occlusion, ischemia is T wave inversion or ST depression, elevation of an ST indicates acute injury, acute MI, and significant Q waves indicates the necrosis of tissue. All right, so now that we know what to look for, we need to remember that the 12 lead views can all show this. So how do we diagnose? How do we know which leads? We see So we want to look at the one with the most significant T wave inversion, significant Q wave, or ST elevation, and that will indicate for us the artery or the location based on those 12 views. Okay, so lead 1, so in V1 through V4, if we're seeing things, then we have to think we're looking at the anterior part of the heart. And that makes sense if we go over here. V1, V2, V3, V4 is looking at anterior heart versus limb leads 2, 3, and AVF is looking at the inferior part of the heart. So if we go back to coronary artery anatomy, then we can start to relate which views relate to which arteries, and that helps your cardiologist to know what artery is problematic. I'm going to slide to this slide for a minute because I think it makes more sense, especially if you haven't remembered your arteries so well. So to orient you here, here's our right coronary artery. Here's our left anterior descending artery. Here's our circumflex. Okay, those are the big ones to talk about for a minute. All right, so then we know that certain leads are looking at certain parts of the heart more closely. So if we talk about the lateral leads, we're talking about lead 1 over here. We're talking about AVL, and we're talking about V5 and V6. So all of these correspond to looking at the left circumflex or one of the diagonal branches off of this left anterior descending, because we're looking at this part of the heart. So if that's where we see the most significant changes in EKG, we have to assume that that's the artery that's involved. If instead we're looking at and seeing problems in 2, 3, and AVF, then we're looking at the inferior part of the heart. We're looking up at it this way, right? So we're looking down here, and so that's going to be either part of the right coronary artery or the circumflex. And then if we are looking at the anterior septal leads, we're looking at V1, V2, 3, and 4. Then we're looking at the left anterior descending here because we're looking across the heart here. Okay. I hope that helps to make that a little bit more clear as we go into this next part. So let's look at this. So this is just one part of a 12-lead EKG, and you can see inverted T waves here. So here's our PQRST, PQRST. And so these T's are in the wrong direction, right? So that indicates ischemia. If we were to see that, we would want to stop activity because we have an ischemic heart at the moment. All right, let's look at this one. So this is a full 12 leads. So remember, I'm going to orient you for a second. Here's 1, 2, 3. This is right arm, left foot. This is V1, V2, V3, V4, V5, V6. All right, and we are seeing the most significant ST elevation in 2, 3, and V3. By looking at those, what we know is that this is most likely the right coronary artery or part of the circumflex. So let's do this one. Again, I'll orient you. Here's V1, 2, and 3, right arm, left foot. V1, V2, V3, V4, V5, V6. So when we look at this, then where do we see the most significant changes and what is it? I would say that it is ST elevation, and that we're seeing that here and here and here and here. We're seeing it in others, but those are the big ones, right? It jumps right out at you. So if we see it in, and there's some in V1, but if we're seeing 2, 3, 4, and 5, then this is most likely we're looking at the anterior part. So that's the left anterior descending if we go back to that anatomy. All right, changing gears one more time. We're almost there, guys. Back in pathophysiology, you learned about lab values. You wrote about how they affected a client, what they indicated, what PT should be aware of, and what precautions to take. So we're going to look at 2 of those electrolyte imbalances that can lead to significant changes in heart rhythm, how to recognize those on an EKG. This can be on a single tracing or on a 12 lead, and those are going to be potassium and calcium. The reason we're looking at these is that they're critical for the ion pump. They maintain ion gradients, and they help with depolarization and repolarization, right? So if we change the membrane potentials, that can speed or slow conduction velocity. And changing those conduction velocities and the action potentials required for depolarization or repolarization, that can cause significant arrhythmia, sometimes life-threatening. If someone is hyperkalemic, so high potassium, what we end up seeing is P waves flatten out, and the QRS becomes wide and bizarre. T waves begin to peak rather than round out. And you can see that here here is a no P wave, this wide bizarre QRS, and then T is kind of weird. All right, and over here what we see is wide QRS and this really peaked T. Okay, with hypokalemia, the EKG is going to show a really flattened T wave and sometimes the presence of a U wave. So what I often give as a hint is if you think of the T wave as a tent that houses potassium ions, if the potassium is high, then the T wave peaks or the tent is tall. But then if potassium is low, the T wave flattens out and a new U wave occurs. Potassium is so crucial for repolarization and maintaining the precise membrane potential. So a decreased potassium causes ventricular automaticity irritability, right? So the ventricle gets really irritated, and then we have these foci outside of the AV node firing. And then there's also poor repolarization, and that can lead to really life-threatening arrhythmias. And one of the common and severe cases is torsades de pointes and ventricular tachycardic arrhythmias. So I want to show you torsades real quick. So this is torsades de pointes. This is not the only cause of hypokalemia, however, it is one. And I want you to say, just by looking at initially, what does it most look like? Well, it looks like ventricular tachycardia, right? You can see all these, what looks like a bunch of PVCs all put together, right? And we learned that more than 3 PVCs in a row is VTAC. Well, that's what this is, except for there's one other interesting thing, which is why it's called torsades. And I'm going to get to my pen for a second and show you. So what happens is we get this polymorphic sinusoidal wave of electrical activity. It looks like this. And so it's a sinusoidal wave of ventricular tachycardia that's polymorphic, meaning that this doesn't look like this, that doesn't look like this, that doesn't look like this. So it keeps changing, but it has this sinusoidal wave throughout it. I lost my mouse, sorry. All right, moving on to calcium. This is the last slide, I promise. When we discuss calcium, if we talk about hypercalcemia, we see short QT intervals on the EKG, so depolarization and repolarization of the ventricle is accelerated. Hypocalcemia, or low calcium, will cause prolonged QT intervals, meaning that it's taking a longer time for depolarization and repolarization to occur before the next beat. So you can see this here in hypercalcemia. Oops, let me get to a pointer, sorry. In hypercalcemia, we end up with this really short Q to T. It gets short, and so we're repolarizing and depolarizing too quickly. And in hypocalcemia, we get this prolonged QT interval. So here's our Q, our S, and T's way over here. So this prolonged QT, you should know, can precede torsades. And so we don't want these prolonged QTs because it can often lead, again, to some arrhythmias we surely don't want. All right, I know that was a lot. Come back with questions and we will review all of this together in class.